For those I haven't met, my name's Renee Fernandez. I'm a family doctor in Vancouver and the Chief Medical Officer of BC Family Doctors. And I've had the interesting journey of being part of creating the LFP payment model over the last couple of years. And so from the very first few moments when we started to have conversations with doctors of BC and government around the idea of launching a new type of blended payment model for family physicians in BC, I've had a chance to be part of those conversations. I was part of launching the clinic-based model for UNET last year, and now we're getting the opportunity to create an extension to the LFP payment model for care provided in long-term care and palliative care facilities, which is what we'll be discussing today, as well as other types of facility-based care. So the other types of facility-based care that are launching as well are inpatient care, as well as pregnancy and newborn care. Today's webinar, however, is an introduction to billing under the LFP payment model for those specific care provided for long-term care and palliative care facility patients. And our hope for today is that we can help you get started about how LFP billing will work in this setting. What we won't be covering is how billing is for clinic-based care. Many of you are already billing that way, and so you don't need that. And for those of you who are not yet billing for that under clinic but are considering it, we will be doing a future billing webinar and videos to introduce you to the basics today. So our 90 minutes together today are a review of eligibility and registration, as well as the specifics of time codes and interaction codes for this specific setting. Due to time limitations, we won't be reviewing the FPSC on-call availability payment, long-term care initiative funding, or supports available for physicians who are not billing under LFP on this webinar today. That doesn't mean that's not coming. We just won't have time to do it in the next 90 minutes because it deserves a full conversation. Further information on all of those is going to be shared by the FPSC. So with that, let's move on to the next slide and really get going with things. With the addition of these new areas of facility-based care, LFP is now one step closer to being a comprehensive payment model that reflects what we as generalist physicians do, comprehensive generalist care. As all of you know, payment schedules are the source of truth about any payment model, whether that's the LFP payment model or fee-for-service. So in this circumstance, the LFP payment schedule is the source of truth about the LFP payment model. The LFP payment schedule is updated regularly based on your input and feedback. Over the last 15 months, we've had 12 versions of the LFP payment schedule as we've improved the payment model based on your input and feedback. The payment schedule that we'll be discussing today will be effective on June 24th, and the payment schedule has now been approved. So you can find that payment schedule on the BC Family Doctors website and the Doctors of BC website as well. In addition, the billing codes for long-term care and palliative care, as well as those other areas of facility-based care, can now be found in the simplified LFP guide. For those of you who are used to using the BC Family Doctors billing resources, the simplified LFP guide is a part of our BC Family Doctors website that strips down the words and the language in the payment schedule to the simplified, easy to understand version of how to do your billing. We have one of these for the LFP payment model, and we have one of these for fee-for-service. For those of you that have your logins at hand, I would encourage you to log in now and follow along as we go through the webinar, as you get familiar with and get to know these codes. As I mentioned, the information that we're presenting is taken directly from the payment schedule, but it is not the fullness of the entire payment schedule. And so we really do recommend that you do take some time to read the payment schedule. We will be sending it out directly by email to all family physicians in the province tomorrow. We just received it today, but we don't have the time today to go over line by line everything in the payment schedule. So please make sure that you read it top to bottom before you start billing these new codes. That makes sure you have a full understanding of the payment model and also provides you with the opportunity to ask questions to our billing support teams if there is anything that's not clear to you from the reading of the payment schedule. BC Family Doctors also has a billing question library on our website. For the clinic-based elements of LFP, we're up to 300 plus questions that are in there with frequently asked questions that physicians have asked us directly. For those of you who are also billing fee-for-service, we also have more than 400 fee-for-service billing questions. And so the questions that you're asking us on the webinar tonight We'll do our best to answer as many of them live as possible. However, given past webinars, we've often had way more questions that we're able to answer live on the webinar. And so what we will be doing is using the questions that you're asking to populate the billing question library so that you have the information that you need. It lets us target writing those billing content to the things that are most important to you. So with that, let's talk a little bit about some key dates. As I mentioned, the LFP payment schedule was approved today and is now up on our website. You will be receiving it by email tomorrow through the LFP newsletter, which many of you receive. And similarly, it will also be available on the Doctors of BC website tomorrow. The simplified LFP guide was updated with the time and interaction codes, as well as the setting registration codes today. More about that in a moment. And we have further webinars going on later this week, as well as early next week. So for those of you who provide inpatient care, on this Thursday, there's an inpatient webinar, which you're welcome to attend. And early next week, we have a pregnancy and newborn care billing webinar. All three of these webinars are being recorded and will be available to view, whether it's for the first time, if you're not able to attend on a different date, or whether you want to go back and review some of the things that we said. And most importantly, the start of billing for LFP facility-based care, including long-term care and palliative care settings, will be on June 24th. So the payment schedule that we'll be covering today, we cannot, any of us as physicians, bill using those time and interaction codes until June 24th. Those codes are being built into Teleplan still, and then built into our EMRs. And by June 24th, we expect all of that work to be done. As all of you know, we're working as quickly as we can, moving at the speed of light to support you. And even then, I know it's probably not moving fast enough. And so we do our best to make the changes based on the input and feedback that you provide us. And as I mentioned, over the last year, we've made more than 100 changes to the clinic-based model. And I anticipate we'll make many more than that to facility-based care as we go through the next few months. Over the last year, more than 4,000 physicians have enrolled in the payment model, and many physicians have written in and commented that for the first time in a long time, they have hope for the future of family medicine and hope for the future of the delivery of primary care to our patients. For long-term care and palliative care, the entirety of LFP billing was constructed around the work that you do, providing care to elders and to people at the end of life. This payment model has some significant changes that are different than fee-for-service. Notable achievements, I think, are that this payment model really recognizes the importance of end-of-life care and the important role of families in both long-term care and palliative care settings. These are really key elements of the patient journey in these settings, as well as other settings. And more importantly, they're things that you've told us have been needed for years. As we go through today, we'll have an opportunity to speak a little bit more about that. As you're all aware, clinic-based care launched in February 2023, and as of June 24th, we'll bring on those 4 additional areas of care that you see listed on the right-hand side of your screen. You'll see that long-term care and palliative care in facilities have been combined together into a single set of codes to keep the number of billing codes to a minimum. None of us need any more billing complexity. We do recognize, however, that these are distinct areas of care with different workflows, and sometimes there's a different group of physicians who are providing care. In some communities, it's the same group of physicians who are providing care. So we look forward to all of you helping us to improve LFP billing in these settings as we move forward, and I trust you'll let us know when we miss the mark. Don't be shy, send in your feedback, let us know where we need to make some improvements on these billing codes, and with that, I'll turn it over to Nick to give you an overview of all of the areas of long-term care and palliative care billing.
Thank you, Renee. I'm also very excited to speak with you tonight as a peer and a colleague who works in long-term care and palliative care. The changes that we're going to introduce tonight, I think, are long overdue, as Renee said, and really do value the work that we do day to day that has been underappreciated for a long time, but also recognizes the things that we needed to support patients and families through their journeys. And when we thought about how to create this payment model for long-term care and palliative care facilities, we really looked back at 2 main things. what is a patient's journey in long-term care and palliative care? And what are the best practice expectations that we expect of each other in the day-to-day work we do in care? So we're going to highlight those again and use those as a foundation as we go into the fee codes for both the time codes and the interaction codes, and help you match them together and see how we came up with these codes. When I think of a patient journey in long-term care, and actually I should have introduced myself. Renee said hi for me, but I feel so familiar because I know a lot of my friends are on the call tonight from long-term care and palliative care. But my name is Nick Petropoulos, and I am a family physician in New West. I'm a medical coordinator at 2 long-term care facilities in Fraser Health, and I am one of the board members for BC Family Doctors, supporting the New West Tri-Cities district. And so that's what's brought me here today to join you as a peer and a colleague for this discussion. So back to what I was saying, when I think about the patient journey, I really think of something called the 4 A's, a concept I borrowed from a friend of mine, Ian Cameron. The 4 A's really talk about, the big steps in a person's life in long-term care. The first being admission, the huge process of them moving from their home in the past into long-term care, and the big bit of work that we have to do with the care team to help this person get adjusted, their family and their loved ones to feel comfortable with us providing care. Along the road, most of our patients are going to have an acute medical event. This takes a lot of time and effort and coordination for us to support the patient in that event. We then, after that event is settled, we will move on to proactive care. These are our routine visits that we do with them, where we come on site, we check in on them, we make sure they're doing well. And then finally, we have actively dying, or the end of life care we do. So again, we are trying to map through the billing codes based upon these events in somebody's life. Next slide. Throughout those 4 main steps or stages in a person's journey, we're going to be doing a number of clinical interactions with someone. What we think of as the long-term care initiatives, 5 best practice expectations. All of us should be familiar with this that work in long-term care already. And for those of you considering moving into long-term care, I'll just review them briefly. But we expect that every resident is going to have proactive visits, at least every 3 months. We expect that patients, residents, and our staff at care homes are going to have our support with 24/7 availability and on-site attendance when we are required. We know the value of supporting our care teams, our residents, their families at care conferences. They can be formal care conferences like the interdisciplinary care conferences that the legislation of BC requires, and they can be informal care conferences when we are brought together to work through an issue or a concern. Today, we're going to be introducing a new interaction code, which supports care conferences that I'm very excited to share with you. And this interaction code specifically lets us support interacting with families. We also are expected to continue doing meaningful medication reviews. Again, that's a legislative requirement to review medications every 180 days. And we are keeping that in mind as we support you with fee codes. And of course, the last expectation is completed documentation. And one change that is really excellent in the fee codes is now we're going to be supported again for our time, which is the hallmark of LFP billing. And so now we get paid to do the documentation and to support the charting so that our colleagues on call, our interdisciplinary team, can have our notes and know what we're doing and thinking. Next slide. So how do we bill palliative care? We're going to talk a lot about long-term care tonight, but let's focus on palliative care. We know that palliative care happens in every setting across the healthcare system. It's going to happen in hospices, in palliative facilities, the hospital, everywhere. We have to be mindful that where we do palliative care, the codes we use are going to be associated with that clinical setting. So if it's in a hospice or another palliative facility or a long-term care facility, it's specifically we're going to use the codes we're talking about tonight. If we're doing palliative care in a hospital, we're going to use inpatient codes. And if we're doing palliative care in a person's home or in our clinic, then we're going to use clinic-based codes. So as Renee mentioned earlier, the new fees will go live on June 24th. So to be eligible to bill the LFP for long-term care or palliative care codes, two requirements. You must be a family physician who provides clinic-based longitudinal care to a panel of patients, and you must be paid under the LFP payment model for your clinic-based care. Longitudinal family physicians who are remunerated under other payment models for their clinic-based care will be eligible later in 2024, and we are still working on the details of that. And so hold tight, we're working as fast as we can to support you. One thing that I'm really excited about is that we are launching the Locum eligibility at the same time as the rest of the LFP physicians. This is a little bit different from LFP initially in the clinic, that it took a little bit of time and adjustment to get the Locum eligibility ready, but it is going to be ready June 24th with the other parts. To be eligible to bill as a Locum physician, you need to meet the Locum eligibility criteria, which we will not go through tonight because that's sort of a base level bit of information. And so refer to our fee guides and our teaching material on our websites. So not only do you have to meet the Locum eligibility criteria, but you also have to provide LFP Locum services on behalf of a host physician. When acting as a Locum for a host physician, the Locum can only use the LFP clinic-based services codes. They can choose to only use the LFP facility-based services, or they can choose to use both. And autonomy and physician's choice is an important concept within the LFP model, and you'll see that throughout tonight as we speak about your choice in which codes to use. So as with clinic-based care, when you submit your Locum time codes, you must include the MSP practitioner number of the host physician on the billing claim. Okay, we're going to talk about enrollment and registration. This one is a little bit tricky for us who have support from our office managers or our billing clerks to do this, but we have to go through it. You'll notice that the goat dropped in the corner there. And so every time you see the goat symbol on the screen, it means that something has changed in general for all of LFP, and it's something for us to take note of. Let's click through Katrina. So all of us who are on LFP currently will be familiar with billing the 98,000 code, which is part of us signifying that we are part of the LFP program and we meet the criteria for the LFP payment model. Starting on June 24th, we can now submit registration codes for the sites, the setting registration codes. So in the case of long-term care and palliative care, we are going to be submitting 98003, and we're going to signify that I would like to bill LFP codes within long-term care or palliative care facilities. As well, we will, as we're choosing to continue to bill LFP in our clinic, we will also have to bill 98002 to signify the setting that we're in. So I think of it as sort of as an umbrella. If you want to do LFP, you have to do the 98,000 code. And then once you do that, then you're going to tell medical services plan where within LFP you want to work. All of us are going to have to work in the clinic because that's a requirement. So we're all going to again do 98002. And then we're going to choose, do we want to bill fee for service or otherwise for long-term care? If we want to bill LFP in long-term care and palliative care, we'll also acknowledge that setting by putting in a 98003. For those of us who are locums, the same applies, except you're going to use the LFP enrollment code 98005, which is in brackets. Okay, so let's just go over a little bit about which facility services are billable. So billing a setting registration code enables you to bill that particular setting under the LFP model. For those areas, the ones that are noted in the left-hand column, you have a choice of whether you want to bill LFP or you want to continue billing in fee-for-service. You do not have to submit a registration code, a setting registration code, because you can choose to continue to bill through fee-for-service or your AP contract. So, for example, myself, I don't do inpatient care. I'm not going to be submitting a code for that setting. I do work in long-term care, so I'll be submitting that code. And if I still did pregnancy and newborn care, I could make a decision. Do I want to continue to bill fee for service because I feel that's better for my workflow and my career? Or do I want to choose to bill LFP for pregnancy and newborn care? So again, it's your choice. You have the autonomy to choose which set of fee codes and remuneration you'd like to do. For the settings in the right-hand column that says not LFP billable, surgical assist, outpatient clinics, emergency care, anesthesia services, they are not currently a part of the LFP payment model, and you should continue to bill using fee-for-service or your AP model. It's also important for us to touch on things that are not billable under LFP. Even for the settings now included in LFP, there are still some services that you cannot be billing using LFP codes. We put together a list above of common codes or items that take place in long-term care and palliative care, but this is not an exhaustive list. So for these examples above, you do not bill using your LFP time or interaction codes. Depending on the service, you're going to choose to bill fee-for-service codes, such as the ones on the left, out-of-province patients, assessments for medical assistance in dying, mental health acts, person with disability forms. We are going to use our teleplan fee-for-service codes that are currently there. Other codes, we're going to bill directly to the patient or third party. And the common ones, for our work in this seminar is out-of-country patients, requests from the public trustee for the incapacity form, disability tax credits, CPP disability, or everybody's favorite, the medical legal requests for a capacity assessment from a lawyer and the amount of work that goes into. So you will continue to bill those to the patient or the third party. Again, these are just a few of the key services we wanted to touch on. There's other excluded services, and we really recommend that you look at the excluded services section in the LFP payment schedule to fully familiarize yourself with what services are not billable using LFP time or LFP interaction codes. And again, these are going to apply the same as they do in the LFP clinics. Facility numbers. Oh my goodness. I know all of you are going, what is a facility number? I've never heard of it. Same as me. But it's a key thing for how the system works in the background. So when billing LFP time and interaction codes, just like your clinic, when we do this for long-term care and palliative facilities, we're going to have to enter the facility number in our claim codes. So if you don't know what your facility number is, and I sure didn't before I was preparing for this, you have to speak with someone like your head MOA, your billing clerk, and this number is currently required on all our claims in the clinic, and so you should be able to find it in your EMR. But if you don't know how to find it, or your staff doesn't know how to help you, you can reach out to Health Insurance BC, and they'll be able to provide that for you. For locum physicians, you will use the host physician's LFP clinic facility number when you do your claims. And so I'm sure all of us would love to have locums and want to have locums, so probably finding out what that facility number is and sharing it with your locums is going to be helpful for you. All right, we're going to move on to a poll. See how much you guys have remembered so far. So you're asked to fill out the public trustee incapacity form. Yes or no? Can you bill LFP time and LFP interaction codes to do this work? It is no. We cannot bill LFP time or interaction codes. We will be direct billing the public guardian trustee as we do now. So let's turn our attention now to time codes and then in a little bit interaction codes. As we start this section, I just want to mention that there are separate time codes and interaction codes for locums, just as there is for the clinic-based care. For simplicity, we're only going to be displaying the codes used for the longitudinal physicians. The locum codes will have the same billing rules, just a different code. And you can find the locum codes in the LFP payment schedule in the simplified LFP guide. I was taking a look at the website tonight. It's very intuitive when you look for the locum codes and the longitudinal physician codes. Pretty straightforward on the website, easy to use. Also to note, physicians who practice in a rural practice subsidiary agreement community are eligible to receive the Rural Retention Program fee premiums on the LFP payment model time codes and interaction codes that we're discussing tonight, just as they are currently provided for clinic-based LFP codes. Okay, how to bill time codes. For those currently billing time at their LFP clinic, you are already very familiar with calculating your time codes at the end of the day, adding each up to a 15-minute unit. As a reminder, only full 15-minute units can be claimed. For example, if a physician provides 50 minutes of indirect patient care, they are entitled to 3 units, to claim 3 units of 98011 for indirect patient care per 15 minutes. For each time code, the number of 15-minute units are totaled across patients to the calendar day, not billed for each individual patient, meaning just because you saw a patient for 15 minutes, you're not supposed to bill one time code for that one person and then move on. That's a lot of work that's unnecessary for you. As a reminder, when you're submitting your time codes, you need to include the start and end times for each time code so that they can double check that you got your number of units correct. Okay, so this is something new for all of LFP, very exciting for us, and we see the goat symbol telling us again. So which payment do you use for the time code submission? So on June 24th, everybody who does LFP in the office, in facility care is going to switch. You will submit your time codes using the PHN and the demographic information for the first patient you saw that day. Specifically, this means the first patient of the day for whom you had an interaction code with in any clinic or facility setting. You will then go and use that same patient information for the entire day, regardless of what setting you are seeing patients in under LFP. So again, I'll try to say it a different way. To be clear, this means that you use a single patient for the whole day for all time codes, regardless of going from the clinic, the hospice, to maternity if you've opted in, to inpatient if you've opted in for LFP. So let's take an example from my practice. Let's say I start at the care community in the morning. I see some long-term care patients. I see Renee as my first long-term care patient of the day. The first person I saw that day, Renee, in that facility, I will bill my time codes under Renee's name. And then as I go to my clinic and I see other patients and I do time codes for my clinic, I will still go back and bill those clinic time codes under Renee, the first patient I saw that day. Let's say you have a day when you don't see any patients directly. You're doing indirect care, you're doing clinical administration care. You're going to use the information of the last patient for whom you had an interaction code that was billed in any clinic or facility setting. So this is intended to make it easier for you to identify the correct patient for your billing submissions. I certainly know for myself that some days I'm sitting there going, which person did I see, and trying to work backwards, and it didn't make sense. So this is going to make things a lot easier for us. The first person you had a clinical interaction with, you're going to bill all your time codes for that day. Okay, let's get into the meat and potatoes of things now, all the codes we're excited to share. So direct patient care time. This also is a change compared to LFP for the office. We're going to see that we have an increased rate that we're going to be paid when we're doing direct patient care in long-term care and palliative facilities. This is paid for weekday business hours at $170 an hour compared to $130 an hour. Again, everything is broken into those 15-minute increments, but I'm just saying 170 to make it easier for you. We also will be paid more for evenings, for weekends, and for overnight, and the amounts are on the screen. Another big change for us, people that do clinic-based LFP and also long-term care or palliative care in the facilities, is that the definition of what is included under direct patient care. So direct patient care time for long-term care and palliative care is defined as when you are doing in-person care with a patient present, and it includes when we're doing indirect patient care or clinical teaching provided while the physician is on site at the facility, providing their care for long-term care or palliative care patients. This means that when you are providing clinically required care in a long-term care facility and you're moving back and forth between seeing a patient, writing your note, talking to the physio for a minute, writing your note, supporting the care team, it's all considered direct patient care. And you would not break out and do indirect care for that time that you're stopping and doing documentation or calling a family. Additionally, direct patient care is not payable for phone or video visits, things that we're doing virtually offsite. and we'll talk more about virtual care in a few slides. Another change that we're going to be showing you tonight is about travel time. This is a new time code for all of LFP. This is to be used when we spend time traveling in the most direct route between patient care sites, including clinic settings, facility settings, patient's home. We're expected to take all reasonable and clinically appropriate steps to reduce the amount of travel time where possible. We can bill up to a maximum of 1 hour per day, and it is required for us to document the start and destination sites in the patient's chart. So for those of us who are currently doing home visits in LFP and have been billing travel time, we used to be billing it under indirect time. When the new code comes live on June 24th, we will use this code instead of indirect time. When you travel from home to hospital and clinic, you cannot bill travel time, even when it's urgent. So leaving your house to drive to the hospital, to drive to the hospice, to drive to the long-term care, when we're on call or it's an urgent call out, from home to the setting, it is not billed under travel time. That is why you will see in a further slide that there's a higher rate for urgent assessments and for direct patient care in the evening and weekend and nighttime hours. The other time codes apply across all clinic and facility settings. So the indirect care time code and the clinical administration time code are the same codes that are currently used in the office. They're going to apply across all the clinical settings, including our clinic. Remember that you won't be billing any indirect time codes while you're at the facility. You'll be using indirect time codes for things like doing phone check-in rounds, reviewing labs for your clinic or the long-term care home when you're at your house. There's only one code to be using for that. For clinical administration time, we anticipate that it's unlikely that us in long-term care or palliative care will be using much of this, but we encourage you to review the LFP payment schedule in its entirety to see the specifics about when it can be used and apply to your own situation as necessary. So how to bill time across settings. So when you're providing clinically required care to patients in more than one setting during the same time period, you're going to bill the higher value direct time code. Now, that's a little bit of a mouthful, sort of we have to explain things by the book, but let's give an example of that. So Thursdays, I'm at Chichen's Way long-term care facility. I'm here all day. My staff gets a phone call from one of my patients in my clinic. My patient thinks they have a UTI. It just so happened that my colleague who covers for me usually on Thursdays is sick and can't answer that call. So my staff calls me and says, "Nick, do you want to take care of this patient with a UTI?" I say, "Yeah, I'm going to fit that person in. I'm going to pause what I'm doing at the long-term care facility. I'm going to call my clinic-based patient, treat their UTI." In that case, you can build a direct time code for long-term care, palliative care, as I am providing care for both the long-term care patients I see because I'm on site, and I'm providing care for that clinic-based patient at the same time. On the other hand, if I finish doing my work at long-term care, everything that I needed to do that day is done, but my son is having a soccer practice around the corner, I don't want to drive all the way home. I want to sit and wait till his practice is done. And I decide to spend 30 minutes reviewing my clinic-based patients' labs before I go and pick up my son from soccer. Then I'm going to be billing indirect time code for clinic-based care. As I'm no longer required to be at the long-term care facility, I just chose to sit in my office at the facility. A lot of my colleagues, as we are designing the fee codes and getting ready for this tonight, had feedback about the limits. And I applaud everybody for sending in their thoughts and concerns and questions about this, because this is how we make changes as we are going along. And so I'm really excited to talk about the limits on time codes. So we have limits for long-term care and palliative care facilities are going to align with clinic-based care. The same time code limits, except each setting has its own limit, and those limits do not apply. So that means that the 120 hours you see here, that applies to long-term care and palliative care, that's its own limit. And your clinic-based time codes also have a separate limit of 120 hours. And so in theory, over a 14-day period, you could work 480 units. in each place, and you can work, in theory, whatever the math is, 240 hours in 14-day period. That's a lot of work, but that's how it goes. All right, so another poll to see if you guys, what do you guys think so far? So Axel Rose was your first patient seen at the LFP clinic you work at, before you then went on and saw patients later that afternoon in hospice. Tommy Lee was the first patient you saw in the hospice. Who do you bill your time codes on for that day? Axel Rose, Tommy Lee? Do you bill Axel Rose for the morning in your clinic and Tommy Lee for the hospice? Or do you bill neither? Axel Rose, though, so the first person you had a clinical interaction with that day, you're going to bill all your time codes regardless of the clinical setting for the whole day. I'm really excited for this section because of the changes and additions to the interaction codes. This is really where your voice, as our community of physicians in these settings, has spoken to what we needed to provide excellent care that aligns with the patient's journey, care that aligns with the best practice expectations. So I'll be going into detail on the 5 most common codes, the top 5 here, and you can refer to our fee guide for procedures and consultations and the other less commonly used ones, the interaction codes. We'll also be then touching on conference and communication codes. As I said earlier, I am over the moon excited about the family conference code. This is something that all of us who've been working in these facilities have struggled with forever, of not getting paid to talk with families, to not get paid to talk with decision makers. We know it's very stressful to support families and not be paid for it. Where are we going to find that time? So we are now going to get paid to support families and decision makers, and I'm just so excited to share that. We're then going to touch on virtual care. So what Renee was pointing out earlier, there's going to be a difference between where we provide inpatient care, in-person care, and virtual care, and what can be billed in each setting for the interaction codes. So as you can see, the majority of services that we're going to do, the interaction, patient connection kind of codes, the majority of these can only be billed when care is provided in person, and that's the left-hand column. This goes back to our learnings from the best practice expectations and the iterations of the long-term care initiative. And really, it speaks to what we learned during COVID, that for the start and the long period of COVID, physicians were not on site. We were encouraged to not be there. And our colleagues and our patients, it was clear that they suffered from us working off site, and suffered in a different way than our patients in the clinic did. We know that when we are at a hospice, when we're at a long-term care facility, we are leaders. Whether you put your hand up and put a badge on saying you're the medical director or not, we're still the leaders of the site. People look to us moment in, moment out for support, reassurance. The families get used to seeing us. The residents get used to seeing us. It's important for us to be on site, and there's value added to that. We were able to advocate for that higher fee for being on site, the $170, and that really was speaking to us losing time and being less efficient when we are providing care on site, because people will stop and ask us things that there's never going to be able to be a fee code for, but there is an acknowledged inefficiency to it, and there's an acknowledged benefit to everybody when we are inefficient in that way, that they need our support. So again, when we look at these interaction codes, we were mindful in saying that some of them really need to have us on site because that's where the value added is. The only patient interaction code that can be provided virtually is the consultation code. So every other moment that we interact with a patient and do something one-on-one with a patient has to be in person. On the other side of things, on the right-hand column, the only code that is billable purely for virtual care is the team communication code. And you have to bill that. You can only bill that when you're off-site. That's not to be used in person. At the end of this section, we will dig in further to the conferencing and communication codes. Just a reminder, let's please review the LFP payment schedule to get familiar with all the ins and outs on things. Again, go to the FAQs and the question and answers that we're going to put on the BC Family Doctors websites, and we'll be teaching this more and more as we go. But for today, we're going to hit the highlights of the new codes. So we also have to remember that there are some limits on interactions. So when there is multiple interactions on the same day with the same patient, we are going to generally only use one interaction code for that patient. This is except for the communication, the conferencing codes, because they are a little bit different. There are times, though, that when we will need to provide more than one service to the same patient on the same day. And for those subsequent interactions, we'll continue to be paid the direct patient care time, because that's when we're on site if we've seen them more than once. And an additional interaction code is billable when the subsequent interaction is for a new condition, it's in a new setting, or because the condition has changed significantly and requires a new assessment, change to management, or now requires a procedure. All right, you saw earlier the long-term care patient journey and the concept that we're trying to build out codes to support all those stages in a person's journey. Here, we're going to map together the interaction codes that we're going to speak to with the different steps on that journey, from the admission process to end of life. So the admission codes, again, this is a change, and you see the goat there signifying it. I'm really excited about admission codes. People time and time again talk to me about admissions are a pain in the butt. They take a lot of time, and paying them as if they were a proactive visit was totally unfair. So we were able to get support and compensation for us to spend the time necessary to do an admission properly. And so when can you bill for an admission code? This interaction code can be billed for the first time the person is admitted to the facility, as well as any subsequent readmissions after a hospital admission. I think that's very cool, because we know that some of our patients go back and forth to hospital, and when they come back to hospital, things have changed. They need a deep dive again of their chart. That we need to review the discharge summary. Often the hospitals don't talk to us properly, so we have to go into Care Connect and go dig for these things. And so now we're going to be supported for that. It's not billable when there's a transfer within the facility. So if a person moves from a regular unit into a behaviors of dementia unit, we will not be able to do an admission code. If a new physician takes over for somebody, again, we're not going to be able to do an admission code, but we'll be compensated for the time we do. And if you're reviewing that person, within the transfer within the facility, and you're there on site, you'll be able to bill $170 an hour for your time plus a proactive visit. So in-person visits, we are used to using these ones as sort of the regular LTC code in the past. We're going to be using this in-person visit code for both proactive care and reactive care. Again, very similar to the 00114 from the past. You can bill for all clinically required long-term care visits, and I'm super excited to say that there is no longer any restrictions about having to bill it every 14 days or 14 days in between. It is your clinical judgment about the frequency of seeing your patients. You know the patient best. You should not be dictated to because of a rule or have to send off fee code notes just to try to advocate for it. If you feel the patient needs to be seen, that's your clinical judgment, and you can see the patient. Again, this supports the best practice expectations, which are many of you familiar with. In the best practice expectations, there's a minimum for our communities in BC of seeing somebody at least every 3 months. If you want to see somebody more often than that, then really it's your clinical judgment, and you'll have to decide when it's necessary to see them and how often that is. And again, there should not be some gestalt ratio of I see everybody X number of days. It is certainly needing to be tailored to the patient's care needs, their medical conditions, and your clinical judgment about how often you need to see them. We recognize that palliative care workflows are quite different from this. In most circumstances, patients in a hospice or a palliative care facility are going to be seen daily or near daily. And this code now allows us to bill that daily care as appropriate, unless you want to bill a higher value code if it's more appropriate, such as the end of life care code we're going to discuss briefly. Urgent assessments. This is payable when a physician must leave immediately from an offsite location to provide an assessment that is both urgently and clinically required for either an acute medical event or a significant change in the patient's condition. You are required to either be contacted by the care staff to let you know that there's a clinically required or acute change. But a nice thing that we're adding, or that's been added compared to our old urgent assessment one, is we are now allowed as physicians to make the decision that an urgent visit is needed based upon results that require urgent attention. So in the past, we had to have a nurse or a care staff ask us to come in urgently, and we had to document that. And now, if we get prompted from an investigation or something else that says we needed urgent assessment, we can make that decision. We have the autonomy to do that. If you are seeing a patient in long-term care, say you're there on a Thursday like me, that I'm just here at the care home anyways, and I'm asked to see a different patient urgently, this code is not billable because I'm already on site when the request was made, and you have to be called from offsite. Another example would be if you are called at your clinic, an offsite location in the morning to do an urgent assessment, but you don't go to see the person until the afternoon. Again, this is not billable because you have to go immediately from an offsite location. And it must be for an acute event or a significant change in their condition. All right. I think I'm most, I won't call it proud because Renee did most of the work on these things and I just gave my 2 cents once in a while. But I'm most proud for us as a community that we now have an end-of-life visit that really recognizes the work that we do. So we are excited to share this code with you. And again, it's the most important, to me at least, stage in somebody's journey through long-term care. And again, we are the leaders in the care home, especially at end of life. I know often the staff and the team needs our expertise to navigate opiates and starting medications. We need to be there for families to help support them and really help them through this last stage. So this fee code recognizes that. So the code is payable for an in-person end-of-life visit. It's a change in the design of the fee-for-service codes. We did have some fee-for-service codes for palliative care, but those were based on timelines. These codes are now based on clinical criteria, which is much better for us because it matches a patient's journey without so much restrictions, and it allows us to be the judge and have some autonomy about whether we need to use this. 2 criteria that is important, we have to document, and it has to be true, is that the patient must be at a M1 most level, signifying that they're at end of life. M1 is a supportive care, symptom management, and comfort measures only level of care. And then the patient has to have a palliative performance scale of 20% or less. And for those of you not familiar with the palliative performance scale, it's a validated clinical tool of prognosis for end of life. So this code will be used instead of a regular visit code for patients that meet the criteria for this code. That being said, it's also key to say that this is not to be used automatically when somebody dies. So you have to be on site, you have to provide the care. Supporting end of life visit is not just something you built in retrospect. Oh, I saw somebody and then a couple of days later they died. That visit I did a couple of days ago, I'm just going to call it an end of life visit. That's not how it works. Again, discharge codes. We've not had discharge codes before. It is quite infrequent for us to do discharges in long-term care or a hospice. Again, most people that are discharged technically pass away as a discharge, and we'll be using end-of-life visits. But there are times that we will be discharging somebody to another care facility, to a hospital, and very rarely home. And so we have a code now to recognize the extra time and effort that goes into this. So for the people that do go to these other settings, a hospital, they're getting discharged, or they're getting transferred to hospital, or discharged from your facility to another one. If you create a discharge summary, if you review their medications and acknowledge that in the discharge summary, and you provide written direction to the patient or to the next team, then you are able to do a discharge. And you're only allowed doing 1 per patient per facility, because in theory, if they're being discharged, then they're not coming back. Again, this is not meant for people that have died. It's not to clean up the paperwork at the end of, somebody passing away and just closing the chart. This is meant for you to intentionally prepare the person to be discharged so that the care team at the other end has better information and support. Okay, care conferencing codes. So this is similar to the care conferencing codes we have now, but there's more flexibility and broader criteria. So when we participate in an in-person or phone video conference with a patient, we can bill the $30 care conference code plus our time. The minimum duration of this conference needs to be 10 minutes, and it needs to be documented in the chart, the start and stop times, and we could do 4 of these an hour. This is going to be a change from the 14077 that most of us in palliative care and long-term care facilities use, because yes, it is 10-minute minimum and not the better portion of 15 minutes, which we all know to be 8. And there is a difference, though, in that we do have the more flexibility and we can combine it with other codes, such as our time codes. So overall, we'll be having better support and financial remuneration when we're doing care conferences. Family conferences is one of the other highlights of things that we're very excited about. So again, as I said earlier, we've never been compensated to talk directly to families, to representatives. And so now we are going to have a family conference code. And this is when we participate in a family conference with one or more of the family members or their legal representatives. So within this, we know we have to, it just can't be just calling somebody up and saying, I'm changing somebody's set asides. They had, a couple of days of constipation. We need to do some meaningful work in this conversation. All of my peers and colleagues on this call know that most of the time when we call families, it is about something serious. And when it's serious, it means that we probably have to get consent to get their permission to make a change or to understand the acute medical event. And we also have to develop and review the care plan. So again, asking somebody, do you approve of giving Senecot? That's not legit. But saying, I think this person had a stroke. I'd like to present you with these options. What do you think of this treatment plan? And then developing and updating the care plan. So both of those parts, it has to be something significant and you have to update the care plan. And for this one, it's a minimum of 15-minute duration and you'll need to enter in the start and stop times. The final communication conferencing code is team communication. So this was created to address when staff call us and we're not at the facility. We can be billed when the staff contacts us or when the physician reaches out to the care staff as a result of investigations that require urgent attention. So that is a change from the old code where, we provided advice to the community through written, faxes and whatnot, because we can only bill those ones if the care staff asked us for a question. So now we're allowed to reach out to the care staff because something is needing urgent attention. This one is only payable when the physician is not on site at the facility. Because if we're on site providing simple team communication, we're being paid at the higher rate of $170 an hour. So we'll be billing this often, maybe if we're in clinic. So we're in our clinic doing clinic-based things. We're doing direct care or indirect care at the clinic, and then we get a call or a communication, and then we will bill it at the same time. So we could be using our time codes at the same time as this. And the minimum duration is 5 minutes to signify that it's a meaningful call. It's not something very simple. Again, you forgot to sign the order. Can you give me verbal for it? Again, you need to have something legitimate and clinically valuable to do. And there is some documentation requirements for this. And I'll just get you guys to read through the details at another time. But because it has a time related to it, 5 minutes, you'll have to do start and stop times in your claim. Okay, last slide before we move on to the poll. Just a reminder about limits on interaction codes. So there is a maximum of 50 interaction codes payable in a single calendar day. The limits for long-term care and palliative facilities are the same as clinic-based care, 50 interaction codes a day, although each setting has its own limits, and those limits are not applied across settings. So in theory, you could do 50 interaction codes in long-term care and 50 interaction codes in your clinic. The maximum applies to all interaction codes in long-term care and palliative care, except for the team communication one. So if you do proactive visits, you do an urgent visit, you do an end-of-life visit, you also do family care conferences, those will all count towards the 50. Okay, so on to the poll. Which of the following codes can be billed when doing virtual care? Team communication is when you can do virtual care, and consultation is when you can do virtual care. You cannot do visit codes, unfortunately, if you're doing virtual, and you cannot do discharges. To do a discharge visit, you have to be on site to do the discharge visit, and to do an actual visit, you have to be on site to do the actual visit and see the person. If you're doing phone rounds with the staff, if your son is sick, like mine is sometimes, and I can't get in the care home, and I call the care home to do some rounds and they grab my doctor book, I'm getting paid at the indirect time for that phone call and that rounds I've done with them, but I'm not doing any visits with patients because I'm not talking to patients, I'm not seeing the patients, and so I'm not going to be billing a visit. And the same thing for a discharge. I had to see the person, prepare them for the discharge, and review their medications and all that stuff that we said was in the necessary bit. And so a discharge must be done on site.
So I'm going to point you back to some resources, because at this point, I think for many folks, they're kind of thinking, okay, there's a whole whack of information that people went through and none of it's stuck in my head. Everything that we covered tonight can be found on the BC Family Doctors website in the simplified LFP guide. The time codes, the interaction codes, anything to do with conferencing and communication related to long-term care, as well as those setting registration codes that we covered way back in the beginning. Some of you might not be members of BC Family Doctors, and if that's the case, we're happy to give you a free 2-week trial membership so you can check it out and see if this is something that's going to be useful for you in your day-to-day billing. If you're not sure if you're a BC Family Doctors member, because I don't know about you, but in January I have to renew 52 different things, and which one were you guys? Shoot us an email and we'll help you figure that out, okay? We've got a billing question library on our website. As I mentioned in the beginning, we're also going to work on some more billing education videos to give you more details, more clinical scenarios. Some of those will come up in video. Some of those will come up on the BC Family Doctors website. So please let us know the things you're the most confused about, the things that make no sense to you, or things that you feel like you want us to do a deeper dive in so that you have a better understanding, so that you can confidently and appropriately bill LFP if you choose to do so for long-term care and palliative care facilities. A couple final thoughts. As I mentioned before, please let us know what's working and what's not. I certainly have no expectation that these codes are going to be right out of the gate, and I know Nick doesn't either. We're hoping they're in the vicinity of close to right, but again, let us know, did we miss the mark? How close did we get? How can we make these better so that they more accurately reflect the care that you are providing and want to provide to your patients in long-term care and palliative care facilities? And of course, all of the questions and answers are not just available for you in the billing question library. You're more than welcome to send us a direct billing question, whether they're the ones that you put in the chat today and we didn't get a chance to answer, or if it's specific registration or billing scenario. You see on your screen here, fp.billing@doctorsofbc.ca. Overall, I think my main take-home message is it's going to take a bit of time for us to figure out all this stuff. Let us know what's working and not working. And please, just be transparent with us. If we missed the mark on a code, let us know.